Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show today, bringing you another really awesome guest involved in science, technology, medicine, all involved in creating a better tomorrow for many people out there. Today on the show, we have the honor of being joined by Dr. Robert Schwab, who is a resident physician, a research specialist, and a hematology oncology fellow at University of Pennsylvania Medicine, part of the University of Pennsylvania Health System. And Dr. Schwab's work has focused over the years on both leukemia and bone marrow transplantation. And previously, he also served as a research specialist in the laboratory of Dr. Carl June, investigating a range of cancer immunotherapies and CAR T-cell treatments. And his current research, which is really fascinating, is centered on the development of novel CAR T-cell therapy applications for addressing inflammation and atherosclerosis related specifically to malignancies, but potentially a much greater picture because, back in 2019, he founded a company called Cartio Therapeutics, specifically the focus of looking at developing cellular immunotherapies broadly in cardiovascular disease. Dr. Schwab did his medical degree and his Master in Science and Translational Research at UPenn, a Bachelor of Arts in Biophysics and Biochemistry from Amherst. And honored to have him with us. A lot of really cool topics to get into today. Dr. Robert Schwab, thank you so much for taking time to come on the show today.
Yeah, no, thank you, Aaron, for inviting me on. I'm very excited to be here. Happy to chat about my research and kind of my prior experiences.
Awesome. And before we get into everything CAR-T and Penn and all that, we'd love to just hear a little bit more about your background, and taking a little look sort of at your pre-medical work and, going back to, sort of undergrad. I saw all sorts of stuff related to optical tweezers and studying germ cells and DNA condensation and tethers and all sorts of really neat biotech stuff. How did you get involved in Tell us your background story, because, again, you're much more than CAR-T.
I definitely have ventured from various topics, and a lot of it is in the biomedical space. And I started out as doing my thesis at Amherst College in the lab of Ashley Carter, who's a biophysics professor there, and we were looking at how DNA folds. So I've always had my hand in molecular biology, and we were interested in we knew how DNA folded in your normal somatic cells, but not necessarily the mechanisms of how they fold in your germ cells, so in your sperm cells or your ovaries. And so we're interested in those mechanisms of how it does that, because it doesn't normally fold. It folds in a different sort of formulation, and it has to be packaged accordingly to travel, as opposed to in your normal bodies. So we built a device called optical tweezers, which it's sort of like relating to if you see an alien movie and the spaceship's above you and they're about to kind of suck you in, and you get in this sort of hologram and this force shield, and you get kind of zoomed up. And that's sort of what optical tweezers is. It uses various wavelengths to bind a bead, and you can measure very small amounts of force of that bead using these tweezers and kind of manipulate it. And so what we would do, we would have DNA pieces that, have these little beads on them, and we'd throw them in the optical tweezers, and we'd put various proteins that help DNA fold and look at the different changes in force over time. And by doing so, you could see how, if you throw in something called protamine, which is a common protein in your sperm, you can see how the DNA folds and measure the changes in that folding mechanism and the changes in force. And that's kind of where my research career started. At the same time, while I was doing a lot of this biophysics, I got interested in immunology, and I was in this course at Amherst College taught by a prominent immunologist. His name was Richard Goldsby, and I believe he still teaches there. And he has founded a couple companies, and he's definitely written a few different textbooks on immunology. And it was in the fall of my senior year, I was taking this immunology course that it really sparked my interest in CAR T cell biology, because we were one of our I'm assuming one of our homeworks or our assignments was to look at a journal article, a recent publication, and kind of present it and write about it. And one of the papers that we reviewed was one of Carl's first paper on CART19 and manipulation for the treatment of CLL. And I was like, oh my God, I was a huge fanboy. And this was back in 2012. And I was still kind of figuring out what I was going to do my following year. And I knew I was going to apply to med school. But, when I started reading about Carl's papers and realizing he was a researcher at Penn, I was like, oh my God, I need to get my hands on this and try to join his lab. So I cold emailed Carl June to ask if I could be a research specialist for a year or two. And he welcomed me with open arms. And this was kind of right before everything was taken off. And it was in the summer of 2013 now that I joined his lab as a research specialist and kind of found my footing in the world of CAR T cell therapy.
And yeah, it's and again, being from Philly and sort of down the street from you guys, it's fascinating seeing how this sort of cellular therapy, immunotherapy, oncoimmunology ecosystem has really evolved over there. We profiled in the past, as Bruce Levine on the show, talking about some of their work, and again, going through some of the papers you've been involved in publishing. You've studied everything from CAR T and CLL, adenocarcinoma. You have a paper on glioblastoma, so sort of a broad range of potential targets. Obviously, not all these cancers are the same, a lot of intricate things to study and modify and so forth. And then in 2023, April, you're on a very important paper sort of summarizing, it's entitled Advances in Cancer Immunotherapies, sort of where we were back then in terms of we got our vaccines, we got our checkpoint inhibitors, our CAR T, various, antibody drug conjugates and all that. Talk a little bit about some of what you learned during that decade or so, and a little bit of how sort of the grade sort of where we are sort of on the oncology front today, and then we'll make a transition in the cardiovascular space. But just love to hear your perspective, having been involved in sort of a broad range of potential targets for these CAR T cells.
Yeah, no, I think I've been my training has kind of evolved during an exceptionally exciting time in the world of oncology. Back when I had just graduated, we really just graduated college and sort of joined Carl's lab. The newest thing was still our checkpoint inhibitors, right? Of treating various cancers and thinking about, ways we can improve the immune system. And then, we had some antibody drug conjugates that were coming out at the time, but BiTEs were still a little ways off, and CAR T for other things aside from sort of CLL and ALL were also pretty ways off. Right. So I got to see things evolve over time, and that was really, really cool and exciting. And it felt like almost every few months throughout my training, we would have a new target and a new immunotherapy or a new ADC or a new BiTE. And all of it, regardless of, what type of mechanism is really trying to harness the immune system. And how can we harness the immune system to treat these various diseases, particularly in cancer? And in cancer, it's really hard, right? Because you're trying to target something that a protein on a cell surface that, might be overly expressed on a cancer cell, but also is kind of on normal tissues, and how to balance that. Carl struck pretty much gold with his CART19 CAR, because, being able to target an antigen on the B cells that, doesn't really have any serious toxicity in a patient once they lose their B cells is pretty remarkable, aside from being a little immunocompromised. And then, as we can talk about later, this same CAR is now being used in various aspects for autoimmunity that's even just as exciting. But I think it's pretty incredible overall how far we've come. And at least in my experience, we've seen things evolve. At least when I started doing CAR T, we are seeing how well it was working for these liquid tumors, which is the main thing I focus on. But the push was, how do we get this to work in the solid tumor world?
Yep.
Right. So, one of the first projects that I was working on with Avery Posey, who is now a researcher over at Penn and runs a lab, was whether we can target these sort of novel glycoproteins that are present on tumor cells, which is sort of a much more universal marker. All our cells and our tissues have these carbohydrates that are scattered all over them, and tumors can have different types of carbohydrates. So we were targeting this carbohydrate that was mainly present on tumor cells. It was called MUC1. And it was interesting because it's the first time that we were using a CAR to target a carbohydrate, not necessarily a standard protein or tumor antigen on a cell surface. So that was one of the first things we worked on. And, I think it was published in Immunity Now, maybe back in 2014, but showed that, in various pancreatic and prostate tumor lines, we can get it to work in animals. And we did. There was a clinical trial using that CAR, but like a lot of the solid tumor CARs, it didn't really pan out. You didn't get great trafficking, you got some off-target toxicity, and the efficacy just wasn't there, and it's been pretty unfortunate. At the same time, you mentioned that I did a little bit of research in glioblastoma, looking at some of the markers that are associated with sort of tumor progression and poor prognosis. And that was much more of a clinical study to kind of see how these things evolve. But meanwhile, I did that with Steve Bagley, who is now heading various clinical trials using CAR T for glioblastoma. And that was the big thing that was at ASCO this year, which is really cool, targeting a couple different receptors, EGFR, which is present in glioblastoma, both the mutated versions of the wild type and the IL-13 receptor. This has been a pretty trendy topic in the world of oncology, is how we can use CAR Ts to treat glioblastoma, because that's one of the few cancers that we have very little second or third line treatments for that are efficacious.
Yeah, and unfortunately, that's one of the big ones that we've been profiling a lot on the show. And it's interesting how MUC1 also has come up recently in other contexts. So I'm really, I'm glad you brought that up as well, because it is again, when you think of that, we don't normally think of it as a sugar or something like that as a potential antigen or target, but it's very interesting how we're seeing these different fields now sort of coalesce. And speaking about sort of fields coalescing, I mentioned in the bio, when we were initially thinking about some of these applications, sort of a CAR T beyond oncology, specifically looking at inflammation and atherosclerosis related to malignancies. And I think this is quite interesting because, if you look at the spectrum, okay, we have, on one hand, we have atherosclerosis, and we'll get into more about what that is. We think about it as sort of this buildup of fats and cholesterol and certain cell products. And then there's sort of this whole area of, the similarities, and you can go down this path as much as you want, between certain cancers and atherosclerosis and all of the, genomic instability and different transcription factors and kinases and proteases and everything else that's happening in the cell wall that, hey, that's not cancer, but it looks a lot like cancer. Talk a little bit about this, because I think before we sort of get into, some of what you're learning with regard to CAR T and atherosclerosis, I'd love to sort of talk a little about the shared similarities here and why this is not that far a leap as some might think it is.
Yeah, no, I think there's a reason why these two aspects and these two topics that kind of evolved for me and overlap. If you think about sort of just cancer in general, it's dysregulation, right? It's a cell that is doing something wrong, that has the incorrect instructions to grow, divide, proliferate, right? And the immune system tries to keep it under control, but at some point it doesn't. Athro is not that different. It's, the starting point are these macrophages, which are a certain type of immune cell that, they start uptaking this molecule of LDL or oxidized LDL at a dysregulated rate. There's nothing that says turn off, stop this process. So both of these starting processes are pretty similar. So these macrophages, they uptake this molecule and they keep growing, dividing, and becoming really inflammatory. And that's pretty much the starting point for how atherosclerosis develops. These are both like diseases of dysregulation, of where one, the cancer cells just kind of divides and evades the immune system.
Mhm.
The macrophage grows, divides, stimulates the immune system. Slightly different pathway here, but in both cases, it's dysregulation of the immune system. Of one, you can't see it; the other, it's overly stimulated. And so you can imagine that, when I started learning about CAR T cells and how to manipulate the immune system, that you could use them for various ways. You can turn them on, over rev it up, as we do with CAR T cell, or you can tone it down with various T regulatory processes. So those are kind of the two different starting points. The thing that interests me the most, and you kind of mentioned it, that, hey, what about atherosclerosis related to malignancy, right? I have in my, most of my fellowship been taking care of primarily oncologic patients. But the amount of times these patients have cardiovascular disorders related to the things we treat them with, or the cancer themselves, is unsurmountable. And, it's a problem in the world of oncology is that, obviously we shoot for cure. We want to get rid of your cancer. But it's a real shame to get rid of someone's cancer, yet to just leave them with pretty bad cardiovascular disease.
Right.
That's still the leading cause of death, right? Cancer and cardiovascular disease, they go hand in hand. And a lot of the things we do makes these things worse. So we can talk about checkpoint inhibition that can cause myocarditis and leads to worsening coronary artery disease. Most of our radiation we do for Hodgkin's lymphoma can cause severe coronary artery disease. Most of our chemos are cardiotoxic. Our anthracyclines can cause myopathies. A lot of our treatments for CML with BCR-ABL inhibitors, TKIs like ponatinib, can cause arterial clots and QTc prolongation and arrhythmias. There are very few of our chemotherapies that do not affect the heart and the cardiovascular system, and that has a major argument that a lot of atherosclerosis or heart disease is not necessarily related to your diet, not necessarily related to your lipid intake, but related to these inflammatory processes, right? Particularly in the world of leukemia and clonal disorders, which is where I focus on. There's this disease called CHIP, and I don't know if this has been discussed on your show before, but so I like to think about it as a precursor to leukemia. So leukemias are, cancers of the blood cells, and a precursor to that are just these blood cells that have these mutations in it. And they don't do anything, or nothing that we know of. They're not affecting your blood counts. They're not causing you disease or cancer. But these genes have multiplied, and you have these mutations that are causing this clonal hematopoiesis of indeterminate significance. That's CHIP. And what we now know is that if you have CHIP, that your rates of coronary artery disease are 2 to 3-fold higher than patients without CHIP. And so this is a disease that not only predisposes you to leukemias, but also predisposes you to coronary artery disease. So these overlapping pathways. And the question is, why does that happen? And, there's been a lot of interest in this disease because of, where it may lead. But, there's thought processes here that CHIP leads to an overactivation of your immune system, that there's increased inflammasomes, there's increased IL-6, and basically more elevated levels of cytokines that lead to this heightened coronary artery disease. So, as a sort of leukemia specialist, I like to think when I'm treating these patients and seeing their various mutations, I like to, think about how this might impact their cardiovascular risk overall, and whether I need them to see a cardio-oncologist, and whether I need to put them on a statin, and whether, we have to have better blood pressure control, or whether they should be on an anti-inflammatory therapy, which is a kind of a new movement in the world of coronary artery disease. which I wish it has taken hold a bit stronger than it has, but we can kind of talk about that in greater detail in a little.
Yeah. Yeah, let's go down that path a little bit, because let's talk about, broadly, because clearly here we have the number one cause of human mortality. I think 1 in 3 people die around the world from cardiovascular disease, primarily caused by atherosclerosis. And as you were pointing out before, this and I'm one of them. My doctor put me on a statin last year after, I'm 56 now, and it's like, all right, your numbers are moving up, and I'm happy I'm on the statin, but understanding, all right, there's a lot more, as you were saying, in terms of inflammation, in terms of all these other processes going on that we still don't have therapeutics for. Hence, I'm very excited about doing this show today. But nonetheless, as you were saying, here we have this thing, it's a plaque. As you were pointing out, we got these macrophages, they come in, they get poisoned because of different signaling, they become this foam cell. Then there's all these other cellular debris and lipids, and it's a big mess, let's just say, of biological events that happens that ultimately leads to these plaques that cut off our blood supply and cause all sorts of problems. Talk a little bit about that in general, and a little bit of how, and we'll get to the paper, the really, groundbreaking paper that you published a couple months ago in a minute, but how you look at that mess that is the plaque as the target compared to, okay, here we got this glioblastoma cell over here, and we now have certain antigens. Talk about how you sort of studied the plaque and as far as deciding what you were going to target initially for this approach.
Yeah, so I think, to talk about the target, I have to go back in time a little bit. So as I said, I started in Carl June's lab back in 2013. I learned, so much about CAR T cell and target development, to the point where, I considered myself a CAR engineer, so to speak. So, I fortunately got into Penn Medical School, and it was in my second year of medical school, and I was able to continue to keep my hand in Carl June's lab, where I was being taught by Dan Rader, who is a prominent lipid biologist over at Penn. And, he does a lot of genetic studies now and runs a great lab. It is a really important figure in the world of cardiovascular disease. And he was teaching us about atherosclerosis and, about the biology and mainly the lipid biology of it. And if you think about what we routinely get measured in our bloodstream to determine cardiovascular risk, when you go to the doctors, you get your LDL and you get your HDL measured, right? And you want your HDL to be high and you want your LDL to be low, but routinely these LDL numbers are high, and we want to reduce them as much as possible because why? Because we know that higher levels of LDL predispose you to coronary artery disease and these plaques. So what happens is, LDL circulates in your blood, you have a meal, and in sort of higher inflammatory states or in any sort of state, a lot of this LDL can get oxidized by reactive oxygen species. We've kind of all heard of that. We use antioxidants all the time to, tone down our immune system or reduce inflammation. The LDL gets oxidized. And this oxidized LDL molecule is what those macrophages see. They gobble up and become foam cells. They become foam cells. They release a bunch of cytokines that recruit T and B cells. The vascular smooth muscle there gets disrupted. The endothelium gets disrupted. And basically you get this proliferation and this necrosis that leads to the plaques. And, these plaques that tend to be more inflammatory, that have more immune system cells in them, are more prone to rupturing. And when they rupture, you get things like strokes, you get your heart attacks. And, if there's a way to reduce that, people try to do that. And the easiest way is to reduce your LDL. So if you reduce your LDL through, diet, that can reduce it significantly. But also, as you just mentioned, statins are amazing drugs. They can reduce your LDL significantly and are very cardioprotective. They also have some anti-inflammatory effects as well. But reducing your LDL is only kind of one component of it, because, if your immune system has already developed a reactivity against ox-LDL, even reducing your LDL, even if you have a little ox-LDL, you're still going to have that reactivity against that molecule. So the question is, how do you fix that dysregulation? And that's kind of what came about during my second year of medical school. As Dan was talking about, Dr. Rader was talking about, this oxLDL molecule being really inflammatory, I thought about, okay, can we, instead of using CAR T to, attack molecules, can we reset the immune system? Can we create regulatory CAR T cells to reduce this inflammatory response? Now, oxLDL is not all that different from a cell, right? If you think about what LDL is, it's called a micelle. So it's basically a miniature cell that has a phospholipid bilayer. It also has proteins on it. One of those is ApoB100, and this ApoB100 protein is responsible to bind to cells in the liver, which help get it uptake, and that's how your kind of cholesterol forms. So when it gets oxidized, this ApoB100 molecule can get modified and becomes an oxidation-specific epitope. And these epitopes are present in variety of autoimmune diseases. They're present in rheumatoid arthritis. They're present in lupus, and so these are sort of pathogenic markers that are present in high inflammatory conditions. So the question becomes, can we target this molecule on oxLDL through a CAR? And it was during my master's of translational research that I think we built maybe 10 different types of CARs trying to target oxLDL, and finally landed on one that actually worked. We were very excited that we were able to, not necessarily bind to something on a cell surface, but to bind sort of this soluble molecule that floats through our bloodstream. So that was kind of the start of this project, which, I say it's the start, that took about 3 years or so to actually find something that worked, because, there have been various papers and research on various ways to target oxLDL with antibodies and how to reduce atherosclerosis that way. So we kind of took that to the next step and took some of these antibodies, threw it into our CAR construct, and sought to target it. And that's kind of why we chose this molecule, because it's kind of the initiating factor for a lot of these processes that lead to atherosclerosis.
Mm-hmm. And this leads to a very important preprint from a couple months ago. Oxidized LDL targeted Chimeric antigen receptor T regulatory cells reducing atherosclerotic plaque development, and rather staggering results in the preclinical models from, as you're saying, suppressing the T cell proliferation, reducing foam cell formation, decreasing plaque deposition up to 80%. Take us into this, because it really is. I mean, again, when I saw this, as I said, I had to have you on the show, even though it's the early days. But this is, again, like unlike anything else that we ever heard of. And for the number one killer of us, I think you're on the right path here. So please walk us through what you learned in this preprint. Take some time with it.
Yeah. So as I said, the minute we found a working CAR that can actually react against the oxLDL molecule, our next step was, okay, instead of creating a killer T cell that might cause more inflammation and more plaque development, how can we create an anti-inflammatory T cell? And that occurs naturally in your body with T regulatory cells, which are characterized by this FOXP3 transcription factor. Mm-hmm. Now, I wish I was the first to use CARs on T regulatory cells. I wasn't. There had been a history of trying to use CAR Tregs before. There's a couple papers using it in multiple sclerosis and colitis, and even trials now doing it for graft-versus-host disease. So CAR Tregs have been a up and coming topic, and a lot of companies have been formed based on CAR Treg therapies. So there's actually various ways to create CAR Tregs. One is to isolate Tregs, but they're a very small population in the body, and then grow them out and transduce them and do their standard CAR T things. But another way to do it is to include the FOXP3 transcription factor in our virus. And that way, we can just isolate your CD4 T cells bulk, and then transduce them with our CAR and this FOXP3 transcription factor that go hand in hand, that one will allow the T cell now to become a T regulatory cell and express our CAR. Because the last thing we would want to happen is have our CAR on a population of non-pure Tregs that, let's say they had activated and they turn into killer T cells. So
Gotcha.
we want these things to go hand in hand, just to be a protective measure that we don't have any CARs on cytotoxic T cells that might worsen disease.
Got it.
So once we kind of use that strategy, we characterize these T cells in vitro, we made sure they're anti-inflammatory and they do the things we want them to do. And then we kind of studied how they interact with macrophages in the presence of OXLDL. And one of the most important parts of the in vitro data was showing that, okay, when we incubate these CAR Tregs with our macrophages with these lipids, what happens? And we showed that we got reduced lipid uptake. We got less foam formation. And I'll be honest, I'm still trying to deduce the mechanism of that, because there are a variety of things that could be happening. In vitro, one, the CAR T cells might be uptaking the OXLDL themselves or just blocking the interaction, but they also could be influencing the macrophage behavior. One proposition that we put in the paper is, okay, are we shifting the phenotype of these macrophages? Because like T cells, like B cells, like almost all cell types, macrophages come in various flavors. So they can be inflammatory or they can be anti-inflammatory. And inflammatory cell macrophages are M1 and anti-inflammatory macrophages are M2. And what we showed in the paper is that we're actually pushing these macrophages into a more M2 phenotype. And classically, M2 macrophages don't uptake OXLDL nearly as much as the inflammatory ones.
Mm-hmm.
So once we kind of established that our in vitro data that these CAR T cells might block this uptake, we wanted to see if this worked in vivo. Now, this experiment we did many, many times just because using adoptive cell therapy in the world of atherosclerosis just hasn't been done very often, or maybe even before. So in your standard CAR T cell models that we do at Penn that we're using for the tumor cell type, we have mice that don't have immune systems. So you throw in a tumor into the mice and you let it grow. And then you throw in human T cells, human CAR T cells, and you see them expand, grow, and ideally kill that tumor. But in the world of atherosclerosis, we don't have immunocompromised mice that we could just throw in human CAR T cells into. Because if you throw in human CAR T cells into a immunocompetent or a mouse that has an immune system, those T cells will just be rejected and not necessarily work. So we had to shift everything into a murine-based system and make murine CARs,
Right.
Which posed challenges on its own, and then put it into a atherosclerotic model that's been defined before, that other researchers would be able to recognize and validate. So standard atherosclerotic models are these LDLR knockout models, which, the LDL receptor is being knocked out. And so the liver can't uptake LDL anymore. It's like a reverse statin, so to speak. So, the LDL is much higher in the blood. And after a couple months, it develops plaque. So what we did then, so we used this model, we basically made these murine CAR Tregs, did the same experiments in vitro that we did with the human ones, with the murine ones, just to validate that everything was working accordingly. And then we threw them into these hyperlipidemic mice, and nothing worked. And this was at the very tail end of my master's year, and we were trying to figure out kind of why we didn't see these CAR Tregs circulate in the blood or anything work. And it was because murine CAR T cells don't live very long in this system. And that's kind of well known. And in order to fix that, you have to give mice lymphodepleting conditioning regimens, lymphodepleting chemo. And I didn't want to do that, and at least initially in this model, because I was worried that, if you lymphodeplete the animals, you're going to influence how much plaque they develop. So that was kind of our first round. We didn't see much efficacy. We didn't see much change in plaque, but we also didn't see any of the T cells hanging around for more than a week or two, which, in the world of atherosclerosis, which is a disease of longevity, you need something that persists for a while.
Sure.
So, that was back in 2019. And unfortunately, I had just become a resident at Penn, and I had very minimal time to do research while I was finishing my residency and even my first year of fellowship. But as a physician scientist, I was able to get back into the lab a couple years ago and kind of restart the project from where we left it off, and with new models and incorporating the conditioning regimen to see if we can get efficacy here. So we basically took similar animals that were slightly modified to have increased ApoB100 expression, which got from the Rader lab, to make it more translational. As I said, the target the CAR targets is the ApoB100 protein that's been slightly modified. And so now we have these animals that express the human version of that with a modification to make it translatable to the clinic. So we did the same model, but now incorporated conditioning. And we found that these CAR T cells now can live at least 6 weeks when we condition the animals. So, in classical models, we know that it takes about 3 months to develop atherosclerosis on a high-fat diet. So we figured, okay, we'll condition the animals, give them the T cells, and then give them another injection after a month and a half. So they have about 12 weeks of where the T cells are present. And what we did is, we obviously looked at toxicity over that time frame. We looked at cytokines over that time frame, and then at the end of the experiment, we dissected out their hearts and their descending aorta, which is a good correlate for sort of coronary artery disease.
Mm-hmm.
And what we saw was that we got a dramatic decrease in the amount of atherosclerosis in the mice that received the targeted Tregs. Now, we used non-targeted Tregs as a control, and we didn't see, which didn't have really much of an effect on the amount of atherosclerosis, but our OxCAR, or our 2D03 CAR Tregs, had a dramatic decrease in the plaque along the descending aorta. And even if we looked at sort of the plaque around the mice coronary sinus, which is sort of the coronary artery correlate, we saw a dramatic decrease in the plaques there too. And what was surprising, increased collagen deposition, which, in prior studies has showed sort of stability of plaques.
Okay.
So, which was really exciting to us. And it's seemingly exciting to other people. So we saw this dramatic decrease. And one of the more important things about the study was that we also didn't see any changes in their lipid levels. So a purely anti-inflammatory mechanism. So you could have thought, okay, maybe somehow these Tregs are reducing lipids because they're binding to them and incorporate them and, I don't know, attacking them somehow. But, we didn't see any changes. We also didn't see any dramatic changes in the systemic cytokines, which is not something we would expect because, the effect that these Tregs should have is at the plaque level and not systemic. Because, the issue of anti-inflammatory therapies in the world of heart disease is that a lot of the ones that have been in clinical trials are systemic, right? And they can cause systemic immunosuppression. So the one that comes to my mind, and I commonly report, is the CANTOS trial. Now, this is a few years old at this point, but it was an antibody against IL-1 beta. And and in this trial, not surprisingly, they saw a reduction in coronary artery events and cardiovascular events, but they also saw increased rates of sepsis because these patients are being immunocompromised. So, if you're trying to develop a therapy for atherosclerosis, you don't want to immunocompromise your patients. You don't want to make them worse off because, unfortunately, atherosclerosis is a sort of a ghost disease. Like, you don't feel it. You don't really know that you have it. And the last thing you want to put someone on a therapy that is going to, put them at risk for various infections or other things. You need something localized. You need something that does not cause systemic effects. And that's why we think our CAR Tregs could be a great option.
Absolutely. No, it's fascinating work. And again, I know these are early days, but, it's really amazing to see these types of results. And again, I appreciate you going into it. It's a very laying out sort of quite an elegant process of ultimately how you have to model these things at the early stage in these animals, as you were explaining. So I really appreciate the story from that perspective. I know, and we chatted before the show, that there's other stuff coming out that we can't get into yet because it's not published. But one of the things that is mentioned sort of has been mentioned in the next steps are the various other now high-risk disease models. And you talked a little about CHIP earlier on. It also lists things here like, as you're saying, the checkpoint immunotherapy-associated cardiovascular disease, other autoimmune disease-associated CVD. Could you just say a few words about what potentially some of the next papers are going to be about, because clearly you're going to go kind of broad here in all the potential CVD applications. Whatever you can say or allowed to say at this point, and we'll do a follow-up show, as I mentioned, when new data comes out.
I think obviously I'm very excited about sort of the immune system and CVD because as I mentioned, the world of oncology has evolved so rapidly over the past 10 years with the immune system. And I feel like cardiovascular disease has been pretty much stalled for quite a long time. We haven't had we've had a couple of new therapies with PCSK9 inhibitors and things like that, but mainly lipid reducing agents. Mm-hmm. And at least in the world of like cellular therapy, that and cardiovascular disease has not overlapped whatsoever. And I'm hoping to push it forward a bit. And, I think my research in particular likes to focus on sort of how this relationship between malignancy and cardiovascular disease, because that's the primary driver of the inflammatory aspects. Mm-hmm. So, the questions I bring up in these various grants and things I'm writing is there a way to prevent some of these cardiovascular comorbidities from happening from our treatments or from the cancer itself? So primarily in CHIP and leukemia, can we do certain interventions to prevent the morbidity associated with it, whether it's sort of our Tregs that reduce the inflammation, or is it a cytokine conjugate? Those are the things we're working on. We're talking at a very prominent time. I don't know if you heard about Capstan Therapeutics that was just gobbled up. That one of the main therapies that they were working on, which came out of John Epstein's lab, was how to fix post heart attack fibrosis, right? So after having heart attacks, can you give CARs that attack fibroblasts that prevent sort of the heart disease later on? So we're working on various other targets that are not fibroblasts related to see if we can reduce some of that similar inflammation, along with thinking about whether these oxidation-specific epitopes can be used in other diseases. So I think I mentioned briefly, that they're present in rheumatoid arthritis, they're present in lupus, and all these patients have worsening coronary artery disease related to that generalized inflammation. So even outside of the world of cancer, can this therapy eventually be used for just pro-inflammatory patient populations? So CHIP patients, RA patients, lupus patients, there's a handful of others where, if that just adjusting your lifestyle, reducing your diet, exercising more, that's not going to reduce your pro-inflammatory environment that is leading to your increased coronary artery disease. So we're going to be looking at a few other models, kind of mimicking those things and trying to move this therapy along and seeing, where this can fit in.
And one other thing I mentioned in the bio, and again, whatever you can tell us, I've done several shows working with the folks at the Penn Center for Innovation and their venture group, and there is a page dedicated to cardio. It says very little at this point in time, but kind of in stealth. But Robert, anything you could say while we have you today on the commercial side of this? Clearly, still early stage, but love to hear about the things that are gestating on in terms of the venture side. Whatever you can say. If you're not allowed to say anything, that's okay.
It's still very early. We started Cardio back in 2019 when we first got this thing off the ground. It's been a little bit of a slower process, primarily because I had to finish my training. But as this research moves along, we recently got a cardiovascular dream team grant that to push this thing forward a little bit more. So we expect that within the year to try to get some more venture capital funding and to see where we can take this in the world of developing a clinical trial and seeing how to find the right patient population to first use this in. So it's fun, it's exciting. I've been very lucky to be surrounded at Penn by incredibly smart people and amazing researchers that have allowed the resources, and the Penn Innovation Center that helps push some of these products along.
Yeah, being a Philly guy, and I love seeing it happen right here in Philly in my backyard. So I just think, again, I so appreciate, I know it's early days, but I so appreciate you telling us the story so far, and I really look forward to continue to follow the progress both in the lab as well as on the venture side, because I really think you're onto something amazing here, and just really appreciating us being able to tell the story at this early stage. But really great stuff, Robert. Again, for everybody that is going to be listening to this episode of the show across the various podcast networks, or who will be watching on the YouTube channel, again, you've been spending time with Dr. Robert Schwab, University of Pennsylvania Health System, doing really amazing things, as they say, to open up entirely new frontiers in cardiovascular medicine. Robert, again, I want to thank you for taking the time out of the schedule. I know it's late in the day to talk to us for a little while about what you've been up to. Obviously, thank you for everything you're doing in developing this new area. And as we like to say on our show, thanks for helping to create a better tomorrow for literally millions of patients out there via what you're thinking about, via the type of work you're championing. Really an awesome story.
Oh, thank you. It's a pleasure to be on, and always happy to chat about it.
Really great having you.